So a while ago, Dr. Salim asked me to work on a supplementation guideline for OBN, and so that's what I'm presenting to you here today. The actual guideline is a document that Dr. Salim will be sharing, I believe, through Slack um, eventually, and it's completed. And so I just have a brief presentation to show to you today, just with sort of the basics from that guideline. Okay, so the main points of the guideline are that supplementation should be temporary, of course, when the goal of the family is to reach exclusive breastfeeding. Parents need to be educated regarding when to wean off and stop supplementation, and I think that's one of the really big take-home messages for us as lactation consultants in the community, because a lot of families are going home, especially recently, doing supplementation from the hospital with no idea when they should be stopping or how to wean that down. The method of supplementation should be easy for the parents to manage at home and a good match for the stamina of the baby. Bottles should always be the last choice for supplementation. That's a big point, take-home point as well, because often that is the method that parents have gone home being taught, and they often have no idea that there's other ways for them to feed the baby away from the chest or breast. When are there indications to start supplementation? So if the parent's goal is exclusive breastfeeding, supplementation should only be recommended when there's a medical indication. So medical indications include the lactating parent being severely ill or unable to provide colostrum or express breast milk. Infants, some of these we're not going to necessarily see through OBN, but I still thought they were important to add. Infants with inborn errors of metabolism, infants who are unable to meet their nutritional needs with breastfeeding due to illness, prematurity, or ineffective milk transfer. So during the virtual visit, we may be able to identify this through decreased urine output based on the baby's age, decreased or minimal stool counts, persistent meconium past 4 days of life, lethargy, or decreased tone. It can also be evident through excessive weight loss, and that's why it's really important, even if the mom is reporting to you what the baby's doing, we need to physically be seeing that baby on the virtual consults. Infants who are symptomatic of hypoglycemia, including jitteriness, difficult to wake for feeds, and of course, if there is an informed decision by the parent to offer formula, that is not a medical reason, but that is a reason why we might start supplementing. Determine if supplementation is necessary through assessment of the infant's visual condition. So this is kind of the procedure you're going to go through. We want to make sure that there's adequate feeding, adequate output, and adequate weight gain. So I took this weight gain, comes from the Toronto Public Health guidelines. And so they're there for you to look at there. And of course, there are other maternal indications that would be indications for supplementation as well. There's a big list of those. They are included in the document. I'll just quickly go over some of them. So obviously, herpes simplex 1. We don't want any direct contact between lesions on the lactating parent's breasts and the baby's mouth. They can continue to feed on the other breast if there's no lesions. HIV infection in developed countries, human T lymphotropic virus. If the lactating parent is on some medication, such as sedating psychotherapeutic drugs or anti-epileptic drugs, we want to look for safer alternatives. So we're always checking to make sure that the medications that they're on are safe for breastfeeding. If the mom has been exposed to radioactive iodine, excessive use of iodine, topical iodine, and cytotoxic chemotherapy drugs. So those are the maternal indications. So I've added this in here. Everybody, I'm sure, is familiar with this chart. This is our guidelines for nursing mothers. So making this available to your parents so that they are able to identify when the baby is having enough wet diapers and enough stools. So a lot of the time, especially if parents go home supplementing from the hospital, they're not really given a clear understanding that if the baby is pooping 10 times a day and having 11 wet diapers, that might be a sign of overfeeding and time to back up on the supplementation. So really important to go over this chart and also make it available to them if they don't have it. Next part is the choice of supplement. So obviously, we would always want to choose the lactating parent's expressed breast milk or colostrum as a first choice. Donor milk is a second choice, although that's not readily available to the general public. I added milk sharing on here. That's an entirely different presentation, but some parents may come to us in a consult and say that they're thinking about milk sharing or they already are doing milk sharing, and that requires sort of a risk assessment discussion to be had there. When no breast milk is available, the next safest choice would be a ready to feed term infant formula. The recommendations through the World Health Organization are that no powdered formula should be being offered for at least the first 8 weeks of life, longer if immunocompromised or born premature. And if at all possible, we want to avoid powdered formula completely. No matter what they're using, whether they've chosen to use powdered formula or concentrated formula, it is part of our scope to make sure that these parents are educated on the safe handling and storage, both of breast milk and each type of formula. So now we know what we're going to feed them. How much are we going to give them? So I like this picture a lot because I prefer just to show the fruits or the those types of pictures. But if parents are already supplementing, they're already really focused on volumes. So showing them volumes of how much their baby's tummy can hold is really, really effective. I've got here from the Academy of Breastfeeding Medicine. These are the suggested supplement intakes for the first few days. Now, these volumes here are a little bit different than what we would see in the hospital, what the parents would be recommended to be feeding their babies if they've been discharged from the hospital, and also from public health clinic settings. I've seen a large variety of volumes. So I know at my hospital, here we see that they're saying in the first 24 hours, 2 to 10 mils per feed. In the hospital setting, they're going to be given a sheet that says 5 to 10 mils. So not a huge difference there, but it is a little bit of a difference. And I usually chalk that up to, you know, if we're talking about breast milk and formula, we're not even, or sorry, colostrum in the first few days and formula, we're not talking about the same thing. So obviously, colostrum is very concentrated. We're not going to need as much of it if we're supplementing with that, if the baby's not latching. If there's no colostrum available, then we're going to have to use a little bit more volume of formula to get the same effect. And I'm happy to share my hospital volume guidelines, but I just thought it was interesting to discuss that there's quite a big difference there. But in this case, I think we're looking at more using just breast milk with the smaller volumes. What about after the first week? So typically we get involved kind of around that time, around the first week. I haven't seen too many babies under a week through OBN, and often they're still supplementing and they really have no idea how much to be giving. So I try to focus, especially if it's been a NICU baby that's been um, discharged, those parents are very much going to be focused on volumes. So I try to take that conversation away from the volumes and back to what the baby is doing. So feeding volumes will be different from feed to feed and from baby to baby. Parents should be encouraged to feed on demand and follow the baby's cues, effectiveness of feeding, and output, not to focus on the volumes. But unfortunately, some parents really like numbers, especially teachers, accountants. We all know the type A personality parents that we work with. Nurses are actually like the worst at wanting to know exactly what their babies are getting a lot of the time. Um, so from day 6 forward, I usually recommend if the baby's not latching at all and you're exclusively pumping for whatever reason, that we want to start with about 60 mils and then base any extra food that's being given after that on the baby's cues. So stopping at that point, not filling that bottle up with 4 ounces just to start, because we know they're going to drink more than they need. So I've added this in here. This isn't really in the document itself, but I just wanted to add it in for interest's sake. So if you're concerned as the clinician, are they feeding enough? So if you have concerns of underfeeding or have a baby over 1 week who's not latching at all, there is a quick calculation that you can do to determine how much volume a baby needs based on their weight. So for babies that are receiving formula, this is something you could use all the way along, because we know as the baby gets bigger, they're going to need more and more and more formula. With breast milk, this is only really that useful in the first 4 weeks of life between month 1 and month 4, because then we know that the volume itself isn't changing at that time. The composition of the breast milk is changing. So um, in the NICU, we use this to calculate for every single baby. I can't say I've ever used it for an OB/GYN patient, but just in case anybody was interested in it, the top volume that you're kind of going to be feeding is 160 mils per kilogram per day. So you're just multiplying that by the baby's weight and dividing it by a minimum of 8 feeds. And that's going to give you kind of an average of how much the baby kind of needs to be taking. Um, on average. But again, this is not meant to really be shared with parents, but more for your reference if you're concerned that they're pumping and bottling and maybe there's poor weight gain and they're not necessarily feeding enough volume. Okay, so how are we going to offer the supplementation? So I would say, I don't know, everybody else probably has different experiences, but I would say probably 90% of the families that I see that are supplementing, when I see them, are offering a bottle. It is unfortunate because most hospitals have done lots of education as to the different methods of supplementation, and bottle really should be the last choice. So when I'm working with parents, the first choice that I always want to go to first is an SNS, a supplemental nursing system, also known as a lactate or lactation aid. And there's advantages and disadvantages to each type of supplementation. The advantages to an SNS is that it allows the baby to be supplemented right at the breast, which decreases the amount of time that they're spending feeding, improves feeding effectiveness at the breast and breast stimulation, which will then increase the milk supply. And if the baby's doing really well at the lactate, it kind of takes out the necessity of adding to pump. So it's less time feeding, no extra time pumping. The best part about a lactation aid is that it is infant driven. And if we know anything about feeding and um, developmentally supportive practices, we know that every type of feeding should be driven by the infant, not driven by the feeder. The disadvantages to a lactate, the baby must be latching effectively for it to work. So if you have a non-latching baby, this isn't really an option until we can get that baby latching a bit more effectively. Can be difficult for parents to do on their own. So some parents struggle with this at home. Some of the supplies can be costly, and they do have to do some really careful cleaning, specifically if they're using formula with a lactation aid. So I know there's lots of different ways to offer supplementation via lactate, and these are some photos of the ones that I prefer to use myself. This is an example using a bottle with a nipple cut at the tip. The lactation tube goes into the bottom. These work by gravity, so the higher you hold it up, the faster the flow. Sometimes you have to hold it up to get the baby drinking, and once they start drinking, you want to lower it to the level of their head so that nothing is moving through the tube unless the baby is drinking. So again, going towards that infant-driven feed. I know there's other ways of a syringe, either with the plunger in or a syringe without the plunger taped to the side. But in my experience, parents find those tricky to use. And the syringe with the plunger inside it, where you have it connected to the tube, parents often then are enticed to push the plunger, which again is not driven by the baby, that's driven by the parent. So it's not as effective. There is a video here. I don't think it's going to work with everybody having their video on. But everybody's probably seen this. So if anybody wants to watch it after, we can post the presentation. It's just showing a lactate tube being inserted. This is just from Jack Newman's website, so most likely everybody has seen it. And it just showed, do you want me to play it, Dr. Salim, or we can watch it after because it's
Watch
going
it
to take
after.
2 minutes?
Yeah.
Pardon?
You can watch it after for the
Okay,
interest of time.
okay, okay. Sorry, I know we're running out of time. The next method is spoon feeding. Works best in the first few days of life when you're looking at small volumes of colostrum, can be used with formula as well. That's an often misconception as parents get sent home and they're like, oh no, we were using the spoon for colostrum and breast milk, but then when we started giving formula, we used a bottle. I don't know why, but for some reason in the hospital, a lot of the time they're directed to use a bottle with formula, but formula can definitely be given on the spoon. Uses the same muscles and tongue position and movement needed to latch and breastfeed effectively. It's again infant driven. If the baby's not hungry, they're not going to eat from the spoon. It's safe for both term and preterm and leads to higher overall breastfeeding rates for both exclusivity and duration. Disadvantages, it's messy, baby must be calm, difficult if the baby is really sleepy, and if the mom is not also at the same time stimulating her breasts after each feed, we can see a decrease in the milk supply because they're not feeding directly at the breast. Cup feeding, basically all the same advantages and disadvantages. The only difference is that the cup works best for at least over 20 mils. We shouldn't be teaching parents to feed with a cup with 5 mils or 10 mils because the cup really has to be tipped a lot into the baby's mouth for them to get that volume. So it works best if it's full. And that's a common misunderstanding about cup feeding as well, is that it should be full. If they're being taught to cup feed properly, there is no higher risk of aspiration with cup feeding, even with preterm populations, than there is with a bottle feed. There's another video here of a cup feed, which if anyone's interested, they can watch on their own. Um, Moving on to finger feeding and syringe feeding. I know at our hospital, we've really moved away from this, other than using a small syringe as a teaser syringe at the breast for small volumes. It's not really, there's not a lot of research that supports that finger feeding, which if for those that aren't aware, I don't have a picture of it, but that's kind of putting the lactate tube on your finger and having the baby suck from it and attaching it to a syringe or putting it to a bottle. It's not well supported in terms of that it's really not driven well by the baby. And there is a lot of information out there now about how the baby's fed and how they're held and how they suck and the flow and all of those things being imprinted as a memory of that feed, and the baby uses that information then for the next feed. So it's if we're using the tube, it's better if the tube is right at the breast. We can use this to get the baby kind of enticed and into interested, but then it shouldn't be used as a full feed, just to assist with latching. Oh, oh shoot, sorry, need to go back. The last one, of course, is bottle. Should be the last choice. Parents will probably be most familiar, so that's one advantage. The baby can transfer the volume faster. That can be an advantage or a disadvantage depending on what's going on with the baby. We know it's going to decrease breastfeeding exclusivity and duration, and we also know it can affect the milk supply if the mom is not pumping and stimulating the breasts when the baby's being bottle fed. I like to explain to all parents that there's a big difference in tongue mechanics and muscles, and it sends a completely different message to the brain, which makes it then difficult for the baby to switch back to the breast. If it's not paced or the flow is too fast, the baby may start to prefer this over the breast and refuse the breast. There's a video here of a side-lying breastfeeding, or sorry, a side-lying bottle feed, which is the way that I like to transition babies from bottle to breast, is getting them into this more breastfeeding friendly position. I show them this with the sound off because I don't really like some of the comments that the person is making. They're like, oh, it's just like breastfeeding. It's not just like breastfeeding, but it is a lot more breastfeeding friendly, this position in particular. But when I teach it, I also have them turn the baby towards on the side towards the breast so that, again, it's more similar to a breastfeeding position, and that's usually helpful transitioning them back to breast. So remembering the two rules. Rule number one, feed the baby. When we're doing supplementation, if the baby isn't latching after 10 to 15 minutes, it's time to move on. Offer supplementation using one of the methods discussed and get that mom pumping, which is rule number two, protecting the milk supply. If the baby is more than a few days old, more than 48 hours, it is time to start getting going with a double electric pump after every feed if the baby's not latching, not feeding well, and or receiving supplementation away from the breast. And I usually recommend that parents continue pumping after feeds until there's no more use of supplementation. When to stop, the biggest part, and sorry, I'm talking really fast, but I'm trying not to take too much time. We want to stop as the baby becomes more efficient, as the milk supply increases, as reported by the lactating parent, and seen by the baby drinking well. When we're seeing a lot of high output, frequent post feed emesis, and excessive weight gain, we have to be thinking, okay, there's a bit of overfeeding going on here, and encourage parents to start offering smaller amounts or challenging the baby to go back to the breast rather than offering more supplementation, reminding them that the breasts are never empty. And often it just takes a few more minutes of going back to the breast for the baby to settle. Encourage parents to focus on the quality of breastfeeding rather than the length of time. It doesn't matter how long the baby is spending there. Obviously, we don't want them spending 2 hours at the breast, but it's more important to look at the quality of the breastfeeding and what the baby's doing at the breast, and focus on the baby's output as the best indicator of adequate feeding rather than worrying so much about volumes. So the recommendations are, we want to prevent the need for supplementation whenever possible, identify early indications or risk factors for delays in lactogenesis 2 and assess for poor milk transfer. Initiate supplementation, there's a spelling error there, when necessary, and provide parents with the information, education, and tools necessary to ensure baby has adequate intake. Follow-up is necessary when supplementation is initiated, so we need to be continuing to follow these mums until it's no longer needed, milk supply is adequate, and breastfeeding is well established. My references are there.